Thank you for your time as we discuss the great debate on policy issue of nurse practitioner state practice environment as presented by bachelor's prepared registered nurses Angela Westover and Tiffany Osborne for Purdue Global University. As we go through this presentation, we'll cover our proposition of the policy, the importance of the policy, the effects on stakeholders, the cost to stakeholders, as well as other issues and research to consider. The American Association of Nurse Practitioners website defines the regulatory structures as such. Restricted practice to be when state practice and licensure laws restricts the ability of a nurse practitioner, also referred to as an NP, to engage in at least one element of NP practice. State law requires career-long supervision, delegation, or team management by another health provider for the NP to provide patient care. Reduced practice is when state practice and licensure laws reduces the ability of NPs to engage in at least one element of NP practice. State law requires a career-long, regulated, collaborative agreement with another health provider for the NP to provide patient care or limits the setting of one or more elements of NP practice. And full practice is when state practice and licensure laws provides for all NPs to evaluate patients, diagnose, order and interpret diagnostic tests, initiate and manage treatments, including prescribing medications and controlled substances, under the exclusive licensure authority of the State Board of Nursing. The current policy on the restrictions of roles for advanced practice nurses is different among states and varies between restricted practice, reduced practice, and full practice. This presentation serves to declare that, on the policy issue of nurse practitioner state practice environments, full practice authority should not be approved, and NPs should only continue to practice under reduced or restricted environments. This policy issue is important because it greatly impacts the future health and wellness of the nation. The health of the public can continue to be improved only when quality care is appropriately being provided by qualified experts. Reforming the system of healthcare has been an incredibly hot topic as America continues to seek ways to increase access to care and decrease the rising cost of healthcare spending. The government and related stakeholders, such as healthcare recipients and healthcare providers, are constantly searching for innovative ways to address the situation. However, some proposals are not in the best interest of all those that would be affected by the change. There are many stakeholders involved here, but we will consider the effects that would be had in the policy change of NP practice environments becoming full authority in all states for the primary stakeholders of physicians, NPs, and patients. Although addressing the physician shortage by allowing NPs to serve as primary care providers seems like a novel idea, the concept is not in the best interest of all those that would be affected by the change. Tackling the demand of PCPs to increase access to care would only be best addressed by increasing the number of state physicians rather than expanding the practice of NPs. The physician shortage will be sustained so long as the NP workforce would be increased to fill PCP roles rather than more appropriately increasing the physician workforce. Physicians have longer and more rigorous training in educational preparation than NPs, which is vital for giving them expertise authority to safely deliver healthcare to those in need and quality control the care that is delivered by other non-physician members of the caregiving team. Many advanced math and science classes are included in the curriculum of a doctor, but not in bachelor's or master's level nursing curriculum. The Medical College Admission Test, or MCAT, is a prerequisite exam which tests the skills and knowledge that medical educators, physicians, medical students, and residents must have in order to be successful in medical school and in practicing medicine. Not all NP programs even require any type of entrance exam. Training for NPs often deals with disease prevention or managing of straightforward or uncomplicated illnesses, so their knowledge and skills are therefore inequivalent to that of a physician, but rather complementary. Reforming the system to expand all 50 states to full practice environments for NPs would remove the need for collaboration agreements that are required under reduced and restricted practice environments. This raises concerns about the dangers of these less qualified clinicians practicing without physician supervision, particularly the risks regarding safe prescribing by NPs for controlled substances and narcotics, as well as accuracy of diagnosing, treatment, and management of complex health needs of the people. At what cost are we willing to reform the health system? Is the change worth sacrificing quality of care? Some studies have in fact conveyed that patients prefer to see NPs over physicians. However, there are also studies which support that many patients prefer physicians over NPs. Above those findings, evidence also shows that patients don't fully understand the difference in clinician background when making their care choice, and therefore may not actually make the best choice of the more qualified, higher educated medical provider that would deliver safe quality care. Employing NPs may curb expenses, but this is likely not a long-term solution and may put patients at risk. The additional costs of the required implementation of organizational changes needed to fully expand NP practice, reimbursement issues, and the funding for NP employment itself negates any short-term benefits. Some deduce that NP expansion to full practice might also even lead to an increased cost in the short term, as NPs may tend to order more laboratory tests, imaging, and specialist visits than physicians do, which again could be considered a result of their shorter, less meticulous programs of study. Healthcare organizations, government programs, patients, and persons across the country are already feeling the impact of the rising cost of healthcare. Impact studies on actual NP cost savings have been somewhat inconclusive, but decreasing costs with increasing utilization could lead to increased and unnecessary spending. Yes, the healthcare system may need an overhaul, but with that, autonomy needs to be given back to physicians to control costs. Third-party payers have controlled the cost of healthcare costs for years now, when it should be the physician controlling the costs. This has also taken away the freedom of physicians to choose how to care for their patients, as they're increasingly limited by insurance companies and other third-party companies. Early studies have demonstrated cost savings in NP services, but if NP practice is expanded to full authority, they will have increase in accountability, which may require higher payments for malpractice rates and then result in NP charging more for their services to parallel reimbursement costs of physicians. Physicians should be responsible for sensibly controlling patient costs and care. We've already discussed a great number of important issues and research to consider that supports a proposition against full practice authority, which included educational preparation, quality of care, and cost impact, but there are several other situations to consider. Not only is the U.S. challenged by a physician shortage, but there's been the complication of a nursing shortage for some time. Even further, there's a nursing faculty shortage, and nursing schools across the country are struggling to expand capacity to meet the rising demand for care given the national move towards healthcare reform. If the current workforce of nurses aims to transition into NP roles under full practice authority, that further contributes to the concern. The practice of medicine specifically includes the diagnosis, treatment, cure, prevention of relieving of human disease, ailment, defect, complaint, or other physical or mental condition. Physician assistants, or PAs, are considered a subfield of the practice of allopathic and osteopathic medicine and surgery under law, and therefore have training that is more comparable to physicians. Between PAs and NPs, the education is of similar length, but PAs have more clinical hours and are focused on medicine, not nursing. Instead of expanding the practice rights of NPs, the focus may be better directed towards increasing PAs to work under physicians, as they'd be better suited to help in the primary care setting.